This week on the BackTable podcast.
Certain things certainly are going to need medical management, maybe even surgery, but I have yet to meet a patient that we could not help in some aspect of supporting their pelvic health, getting their musculoskeletal system to function better, which then alleviates some of their symptoms, whether it's bladder, bowel, sexual function. There is always a mechanical component that might not be where it originated from, where the symptoms originated from, but it becomes a contributing factor to their ongoing symptoms. So I would say there's no one I can definitely not help. Sometimes PT is not the sole answer, and that's where collaboration comes into play.
Hey folks, my name is Dr. Amy Pearlman. I'm a board-certified urologist with expertise in sexual, hormonal, and genitourinary health, and I'm co-founder of Prime Institute. And I have one of my most favorite people with us today on the BackTable Urology podcast. I have Dr. Victoria Mallow here today. Tori, I don't remember exactly how we initially met. I think someone mentioned your name, and then I went up and I met you in Delray. And if there's one provider that my patients routinely come back and they say, this person changed my life, it's people like Dr. Tori Mallow. So thank you so much for being with us today on the BackTable Urology podcast.
Thank you. Thank you for having me and for your kind words.
You're so welcome. So Dr. Mallow is a pelvic physical therapist, and her practice is in the Delray area. So just about maybe an hour and a half from me, which is nice. And, you know, a lot of people listening in, I think a lot of people have heard of certainly physical therapists and maybe less so pelvic physical therapy. So why don't you give us a little bit of a rundown? What did your education look like to get to where you are today?
Sure. So to become a physical therapist, nowadays you have to have a doctorate degree. So it's 4 years of undergrad with, of course, a lot of health sciences as a background. And then you go into a doctorate program that takes 3 years. And over the course of that 3 years, it's a mixture of didactic work as well as clinical education. You get to travel and spend time in all different settings and really explore different aspects of physical therapy. There are some optional residencies and fellowships, but the vast majority of therapists go right into practice. They gain their experience, hands-on in the clinic. And then for pelvic is the most specialized field within physical therapy. So it's the one specialty where you need to have additional training to really feel confident in going out and treating patients. In PT school, they give you a very broad overview, very general, baseline knowledge of the pelvic floor. And then it's usually either, people rule that out completely or they want to go in and really dive into the coursework and pursue pelvic. And so that's what I ultimately ended up doing. I went into the field for a few years, circled back to pelvic, and that's when I went for the additional coursework in that field.
So I'm curious if it's similar with urology. I mean, it's so rare that someone starts medical school and says, I want to become a urologist, unless they have a family member who's a urologist, or they at some point during their childhood and adolescence met with a urologist, maybe had a surgery and that was impactful. Does anyone actually go into PT school saying, I want to be a pelvic physical therapist?
It's few and far between. I've met a couple people over the years that have, but the vast majority of people, including myself, never heard of it. So everyone goes into PT school wanting to, work for these professional sports teams, work with athletes, and then you get exposed to all these different areas these different avenues you can go down. So when I went into PT school, I was thinking acute care. And I got exposed to pelvic, and at first I was taken aback by it. And then when I really observed and read articles about it, I was like, this is really cool. You get to help people with things that they otherwise wouldn't want to talk about and wouldn't necessarily seek help for. So that's what drew me in. And for a lot of other people, it comes after a personal experience, like you mentioned, maybe childbirth even. So those things definitely help spark your interest in it. But yeah, most people don't go in even knowing what it is, I would say.
And to go back a little bit to your pelvic PT training. So I heard from some of my other pelvic PT colleagues that when you go in, you essentially sign a consent that you're going to be doing pelvic exams on each other. Is this true or
Yes.
false?
Yes. Yes, this can be very intimidating, but once you've done it once, you're like, oh, this is no big deal. You basically walk into a conference center with at least 50 other PTs from around the country that you've never met before. And you walk in, you introduce yourself, and you're like, hi, I'm about to do your pelvic exam. And because they want you to have, exposure to so many different bodies, they encourage you, the courses are usually over a whole weekend. So they encourage you over the course of the weekend to treat as many people or evaluate as many people as possible. Therefore, by the end of the weekend, you've had at least 10 different people all up in your business, and you get to know each other pretty well by the end.
Oh my goodness.
Yeah.
That is fascinating, but I'm sure it keeps a lot of people, I'm sure that's a barrier for a lot of people being interested in pelvic PT. Would you agree with that?
I would say so. Yes, it definitely, you have to really have a passion for it, I think, to go through that. But on the other hand, I think it helps make for a better therapist because you sort of know how it feels to be on the other side of the table. So even if you haven't gone through some of the struggles that your patients will present with, you've at least known what it's felt like to have a pelvic exam because it's different than one by a GYN. You just gain a different, perspective as to, do your patients feel comfortable? Do they feel safe? Are they embarrassed? And so it really has helped me, especially with navigating how to set up my office to make sure it is like a more comfortable space and you're not just like, here's a paper gown, get undressed.
Yeah. There are 3 experiences that pop up like in my life that really help me understand how best to counsel and make patients comfortable that are related to urology and procedures. One is, this was probably 20 years ago, I was having a mole removed on my arm and they injected lidocaine and that really hurt. And oftentimes we downplay it. We say, oh, it's just a little stick and a burn. It took my breath away. And so now for a lot of the procedures that I do, I use topical anesthetic first before I even inject lidocaine because that injectable lidocaine is not comfortable. So that's one thing. Another time, this is maybe like TMI, I thought I was retaining urine in my bladder. So I tried to catheterize myself at home and it was terribly uncomfortable. That completely changed my perspective on a simple catheterization. And then having a urinary tract infection. So often in urology especially, we say, oh, it's just a simple, uncomplicated UTI. And then you get a UTI and it puts you in fetal position like razor blades. And it really changes your perspective that when someone calls in and they have UTI symptoms, you want them to feel better as soon as possible. So I agree with you. I think those experiences where sometimes we become the patient really help us become really empathetic providers.
Yeah, definitely. You can't do it and not feel for your patients afterwards.
Absolutely.
It's just a very vulnerable place to be.
So comparing to other physical therapists who don't have the pelvic floor PT training, if someone were to see a PT for something else and say, oh, I have a question about a pelvic floor symptom, how much or little does that PT actually know or could help that patient?
It's definitely very different. And I can say that confidently as someone who initially went into, like I said, acute care, and I did spend some time in orthopedics. Your knowledge base of the pelvic floor is minimal before you go through these trainings. The pelvic floor, you might know the names of the muscles and roughly where they are, but to really understand how they integrate with other parts of the body and how one thing can be contributing to how their pelvic floor functions, it's like a whole nother level. So I always recommend that, if someone's having pelvic concerns, that they do get a consult by a pelvic floor therapist. And I have plenty of patients who, I co-treat with orthopedic PTs, general PTs, and maybe they're working on other things and we're communicating about, how their treatment plan can influence what we're doing and vice versa. But you really do need that skill behind you to effectively treat the pelvic floor.
So when I see patients, a lot of my patients are being seen by physical therapists, and I explain exactly what you're saying, which might be helpful for, a lot of the urologists tuning in, is I say most PTs have no expertise in the pelvic floor, and that's why I recommend that you see someone like Dr. Mallow. But I've had patients that see you and their knee pain is better. So oftentimes if they're not seeing a PT, but they have shoulder issues, knee issues, low back issues, that can also be addressed by a lot of PTs because you already have that baseline foundational PT knowledge.
Yeah, and that's the important piece that, when I work with other pelvic PTs who are coming into the field and mentor them, I always tell them, first and foremost, we are physical therapists. Like, you have to know the body from head to toe. We just have that added benefit of the clinical experience and the knowledge to in-depth treat the pelvic floor. But, people need to understand, or therapists need to understand, how the pelvic floor is influenced by things like the TMJ, by ankle mobility, by someone's gait pattern. And that's why I will take every opportunity when a patient comes in my door and we're working on pelvic health. I will take the opportunity to address any other concerns, because it will not only help with those specific complaints, but it's going to help with the pelvic health as well. So yeah, people need to, understand that we know the whole body.
One of our mutual patients was getting ready to fly to Mexico to spend God knows how many thousands of dollars on stem cells in his knee, and went to you and his knee pain is better. So I'm glad that I played a small role in saving him some money, even though you did all the work there. So the next part of this podcast that I really want to focus on are the types of patients that you can help. And when I was at the University of Iowa and I was trying to get a lot of my colleagues and residents to make the referrals to our pelvic floor physical therapy colleagues, I think some of my colleagues, they were worried they were going to send the wrong patients to the PT, or they were worried because the patient that we were seeing was a really challenging, complicated patient, and they didn't want to send this patient that was so complex, or they didn't think that anyone could help them. They didn't want to send him to the physical therapist because they didn't want to, let's say, dump this patient on someone else who could not help that patient. So I'd like you to share with us, who are the types of patients that you can help? What do they present with in terms of their symptoms? And as people, in terms of their mindset, who are those people?
So especially talking from the urology background, really we see anyone with, well, certainly pelvic pain. Pelvic pain is a huge population for my clinic, but voiding dysfunction, urinary urgency and frequency, feeling like you're not emptying the bladder all the way, those patients that come back repeatedly insisting they have a UTI, and every time you culture them, it's negative. Those are our people. That is pelvic floor dysfunction. Even the patients who do chronically get infections and UTIs, a lot of times we can help them as well. When we're talking about men, BPH, we can help with some symptoms associated with that. Men who have been diagnosed with prostate cancer, pre and post rehab is super important. When I talk to people out in the community who don't have a medical background, just to summarize it, I say, if you have trouble keeping it in, trouble getting it out, or pain with it, we can help. But it basically encompasses, all of that, because no matter what is driving the symptoms, even if there is something very medically, systemically wrong, like cancer, let's say, there are aspects of the musculoskeletal system that we can help with. And at the very least, we can help improve their day-to-day symptoms. And that's where we come in, and that's where the collaboration really is key. But any of those symptoms, bladder, bowel, and pelvic pain, that's where we are, and sexual function.
Yeah. So all the patients that we as urologists struggle to treat, right, are your ideal patients. And what I learned from that, when I sat down with the pelvic physical therapist at Iowa, I sat down with each one of them and I asked them, who can you help? And they described all the patients that you're describing, and it blew my mind, because I realized, oh my God, we all have our own pain. All of the patients that are painful for a lot of surgeons are the bread and butter and the people that you want to see in my office. So I would tell my residents, do not feel bad for sending this young man with chronic scrotal content pain to a physical therapist. This is the life that the PT chose. They want to see those patients. Don't feel bad for making that referral. But it took a lot of communication. It took a lot of sending those patients and actually getting feedback from patients so that the patients could tell us they were getting better. I always found it useful when patients would come back for their follow-up and they had no issues anymore, I needed to hear that personally from my patients for them to say, I saw the person you recommended. Now I'm better. I don't have any concerns. The problem is that a lot of those patients, when they do better and they no longer have concerns, they might cancel their follow-ups. And so as the urologist making that referral, they end up somewhere in the abyss and we don't know what happens to them. So it was really helpful in my early career to get those patients to come back to say, thank you so much for that referral.
Yeah, those are exactly the people that I love to treat. I mean, I had a urologist call me one time and she said, I need to know what you're doing because she said, my patient has had 2 TURP procedures and he came to pelvic floor therapy, came back, most of his symptoms were gone, and they actually canceled the follow-up TURP that was scheduled. And she even said, she's like, I didn't want to send him to you because like, we're beating our head against the wall. And I'm like, no, that's who I want. Like, let me take them off of your plate. I always tell, people in the medical community, when you have that patient that you see them on your schedule and you're like, oh God, not again. I don't know what else I'm going to do. Like, send them to us because a lot of times that collaborative approach is what's needed. You can give patients medication or do procedures, but addressing some underlying musculoskeletal issues can go a long way as well.
Mm-hmm. Pelvic floor physical therapy isn't in the BPH guidelines, but I agree with you. I think before surgery, we should be sending patients to pelvic physical therapy. And when someone comes to see us after surgery, if they still have symptoms, that's a really good time to send them to a pelvic physical therapist. That actually is routinely when I was seeing patients with voiding dysfunction at the University of Iowa. If it was like an initial visit with me and they had a bunch of lower urinary tract symptoms, we oftentimes label it as BPH without even any evidence of BPH. So I like to broaden that to bothersome lower urinary tract symptoms. And let's say I was starting them on something like Cialis or, Flomax. I would offer them pelvic floor physical therapy during that medication trial. And a lot of those guys got better. Or if they didn't get better, then that just reinforced the decision that, yes, surgery seems like a really good next step.
Yeah, absolutely. I mean, a lot of these people, like us as people, it doesn't matter if you're men or women, you're never really taught how to pee and poop.
Mm-hmm.
So people become, kids with voiding dysfunction become adults with voiding dysfunction. And just teaching someone how to alter their posture a little bit when they're trying to empty their bladder or empty their bowel, they're like, wow, I didn't even know that was a thing. And we didn't do anything to change the size of the prostate, to change like anything underlying it, but we're just giving them a mechanical advantage to help mitigate some of their symptoms.
Oh, I love that. So why don't you walk us through how do you teach a grown person how to pee and poop in the office?
So certainly depends if you're standing or sitting. So for our men who typically would stand, if they're having trouble fully emptying their bladder, I usually tell them to put one hand on the wall behind the urinal or the toilet and lean their body weight there. That way they're not using some of their muscular energy to help support their posture. They can really focus on relaxing. And then we go in depth as to what does it mean to relax your pelvic floor. I always say, imagine your testicles are dropping towards the floor and you're breathing in and out deeply into your abdomen. Once they can get that connection and really find their pelvic floor, and then combine that with the positioning against the wall, usually that helps. With sitting on the toilet, the first thing we need to do is make sure they're sitting and not hovering, because a lot of times people will get asked, maybe by their physician, about their urine stream or about urination. And they say, I can't urinate, or I can't empty. Right away, they get given a medication where, did you even ask if they're sitting? Because if they're hovering, of course, their pelvic floor can't relax all the way. So this is where we have an advantage in terms of usually being able to spend more time with patients and get into like the nitty-gritty questions. When we ask all these in-depth questions, it drives our treatment approach, and we can find things that can make a big difference in their life that would otherwise go unnoticed. So I always ask people if they're sitting. And then if they're sitting, again, we go into how to connect with your pelvic floor to know what it is that you're trying to relax, and then really breathing through that and allowing the sphincters to open.
And then what about pooping? What's your guidance there?
So with pooping, I always tell people it's a multimodal approach. You have to have the right stool consistency as well as the mechanics. You have to allow those muscles to relax. So if I use this pelvis model here as an example, because the orientation of the muscles go around in a circle, you have to think of it like a trampoline. So when we're having a bowel movement, we want that trampoline to descend a little bit and allow for things to come out, versus when you're out walking around, you want your pelvic floor engaged enough to be in like a neutral position. So the squatty potty is a great tool that I recommend, because when you can get your knees a little higher than your hips, the puborectalis muscle going around the rectum relaxes better, and it puts you at a mechanical advantage. And from there, we talk through how to exhale to alleviate pressure when you bear down, versus as soon as you close your glottis, you're building up pressure in your abdominal cavity and you end up straining those muscles. So those are some of the examples that we use.
And then in the office, do you like watch people on a toilet, or what's the setup there?
So I break out my squatty potty. I position them usually in either thin clothing, like if they already come in with like yoga pants on, or we'll put them in a gown. I get them positioned on my treatment table just as if they were on the toilet. And what I typically do, with permission, of course, I put my hand underneath them. So when I feel here at the perineum, I can feel what their muscle coordination is doing. They also have the feedback of knowing where to focus their attention. And from there, we go through, what does it feel like and what does it mean to engage your pelvic floor into like a Kegel? What does it mean to really relax? And then from there, I take my hand away and they start practicing really how to bear down effectively. And I tell them, practice this, commit it to muscle memory, go do it at home. And they come back and they're like, I can't believe I've been pooping wrong my whole life.
And that's exactly what I explain to patients is I say, you need to see Dr. Mallow. She teaches grown people how to pee and poop. And people are up for that because whoever sits down with them to teach them how to do it, nobody does. And yet it is something that drives so many of the pelvic symptoms that we're treating in a urologist's office. It is crazy. So on the subject of cues and understanding whether or not a patient is doing or engaging the right pelvic floor muscles, let's talk a little bit about like the post-prostatectomy patient, where oftentimes in a urologist's office, we might give a patient a handout that says, go ahead and do some Kegel exercises however many times a day. And we say, do it like you're pinching off your urinary stream. Now, I've been told from some of my colleagues that that might not actually be the best cue. When I try doing that for myself, I'm like squeezing the muscles posteriorly. So what's the best cue to tell patients to do a proper Kegel?
So if we're talking about a male patient, then I typically say, okay, you know how when you have an erection, you can use your muscles to lift the penis? And every guy says, yep. That is what I want you to do. As soon as I say that, the light bulb goes off. Because yes, usually men come in, they're squeezing off the anal opening or they're squeezing their glutes. And really, for a pelvic floor contraction, we need both a squeeze and a lift to happen. However, when we're dealing with someone with prostatectomy surgery and they've just had their prostate removed and that internal sphincter is gone and we need to really strengthen, we do focus a little more anterior, because in a basic Kegel, we want everything kind of engaging. For the purpose of that patient, that's when I usually cue them to lift the penis to make sure we're really getting the anterior portion. And it really is very, very effective for them. If it's a female, let's say, the best cue that I find is, imagine there's a straw in your vagina and you are sucking up a thick milkshake. That
These
tends
are
to
great.
work.
I love this. I think these are really good prompts that we can start telling our patients, because not all of our patients may be open to seeing a pelvic physical therapist. And so I think just the next better step from a urologist perspective is let's make sure we're giving the appropriate cues.
Exactly. And on that note about people not being ready, there are options for telehealth, for virtual pelvic floor therapy. Not every therapist does that. I am one that actually does do that, and I love doing that just for that reason. I don't want someone to go without care, because whatever the reason may be that they don't want to come in. It could be trauma. It could be that they don't want to be physically touched. But just giving patients education around this topic in whatever way we can is definitely going to be very helpful.
So that's a great segue to my next question, which is, what should a referring provider like a urologist be telling our patients when we realize they should see a pelvic physical therapist? What quick education should we provide that patient so they are prepared for what they're going to go through in your office?
So especially I can speak for my office, I would say no one is required to do anything they're not comfortable with. We have so many ways to evaluate the pelvic floor, and what we're really evaluating is that muscle coordination piece, muscle activation, strength, and the ability to relax or the elasticity of the tissue. But we can do that, we could achieve that information in so many different ways. So the internal exam is what everyone thinks of as standard, and that could be what turns people off or makes them a little afraid. That is definitely a portion of what we do. But again, we have ways to modify, otherwise. But you should have them expect basically that they're getting an evaluation of how their muscles are functioning, maybe even how their nerves and their other soft tissue are being affected by it. All of that is what we're trying to gather data on. But we do look at you from head to toe. So first and foremost, it's physical therapy is what they need to understand. Because a lot of people walk in here and they're like, my doctor sent me, but like, what are you? Like, who are you? Do you have a degree? They don't really know what this is because it's not talked about so much. But that's really what we're trying to gain is like mechanically, how are these muscles functioning? Are they integrating with the rest of your body and your movement patterns the way that they should? And if not, that's where we start to see symptoms arise.
And in terms of if our patients ask, what kind of clothes should I wear to my PT visit, what should we tell them?
I always tell them just wear whatever you're comfortable with. We do usually do some form of movement, but I have people that come in from work and, they're not dressed ready to do, a yoga pose or something. We have gowns. So we'll have people change into a gown and we're very careful and know how to position people to preserve their modesty and make them feel comfortable. But, the very beginning part of a visit is where we sit down and we're just talking for a bit. Whether it's their first visit or a follow-up visit, we always start with talking about what they're experiencing. Their history is a huge piece that drives our evaluation and our treatment. So it's not just get on the table, let's evaluate your pelvic floor. There's a lot of other things that go into it as well.
Now, what I was surprised by when I came to your office is I knew kind of a lot of the pelvic PT or pelvic focused exercises that you might recommend, but you also have people do things like squats and lunges. So even what we would consider to be regular PT or physical exercise can still be part of pelvic PT. Can you explain why that approach is also relevant to the pelvis?
Yeah, so there are so many connections to especially the back and the hip and everything that just attaches around this whole bony pelvis. So for instance, let me give you this for an example. The obturator internus, right, rotates the hip. It is a hip muscle. It's also a pelvic floor muscle. The adductors, where they come in and attach up in here, when those are really tight, it can influence the muscles around the urogenital triangle and lead to issues like urinary leakage or increased tension, which makes it more difficult to empty the bladder all the way. The hamstrings are involved. So you have to look at how other aspects of the body when you're moving integrate with the pelvic floor. And that's why we always say here that we treat you as a whole person. If we're hyper-focused on just the pelvic floor muscles, we will miss key bits of information that will help get somebody better. For example, I had a male patient get referred to me for testicular pain, and he had a small varicocele on imaging. And the urologist said, it's pretty small. I don't think it's small enough to cause that amount of pain. Well, when he came in to see us here, we did our evaluation. Turns out he's having an issue with his psoas muscle that's right up through the abdomen, driving and referring pain down into the testicle. And when we treated his psoas, his testicular pain went away. So we have to look at other areas of body and we have to look at movement patterns. For our male patients, what I tend to see most often is their hips are really tight. So the posterior capsule of the hip gets really tight, and then that whole mechanics of the ball and socket joint gets thrown off. They end up developing things like hip impingement or labral tears, and that can be going on for years until suddenly they have pelvic symptoms. And it's because one of them is driving the other. So when we do our treatment, we're looking at, okay, let's get the mechanics working right at the hip to help the pelvic floor be able to function the right way. And then for females, it's usually more of a lack of stability. And when we have hip weakness and the hip muscles here that are supposed to be supporting the pelvis, when they are weak or not super stable, the pelvic floor takes over, becomes overactive and tight, and that's when we get our pelvic symptoms. So that's why for that population, we tend to work on a lot more of stability while also bringing down the pelvic floor tension.
Wow. Now, for a lot of the patients that we see as urologists, our patients are going to be familiar with a prostate exam. And if they've seen a gynecologist, they're going to be familiar with a vaginal exam. How does your exam, when you are doing an internal exam, how does that compare to an exam that we might do in the office?
So with our exam, we are not really looking at things like the prostate or up near the cervix. We are really, if I use this model as an example, when we come in vaginally here, we are assessing all the way through here, all the structures of the pelvic floor. So we are feeling for muscular tension. We might even be looking at fascial connections in and outside of the pelvis. Inside of the pelvis, we're able to palpate near where the pudendal nerve is to see if that's a driver of their symptoms. But we're staying really around that pelvic basin, really for both vaginal and rectal exams. And part of our exam also, a really cool thing that we can do is when we have our palpating hand internally, our external hand can help make changes at their hamstrings or their back. So if I kind of slack the tissue on the hamstrings as I'm internal and they say, wow, that really made my pain better, I know that those hamstrings pulling on the ischial tuberosities are going to be a big driving factor to their pain. And therefore, we go into more of that orthopedic treatment with some hamstring treatment, not just the pelvic floor.
So how long would you be, let's say, like inside a vagina, or I don't know if this is the appropriate way to ask this question, but like for a digital rectal exam, it's like 10 seconds, right? How long might you be doing that, being in the rectum and doing those maneuvers and in a vagina so we can help prompt our patient like, okay, you got the DRE today, the pelvic PT visit's going to be a little bit different, and this is how. How long are you in there for?
That really depends. It depends on the patient and their comfort. And first and foremost, that's what we prioritize. So I always describe the evaluation to someone. I'm standing next to them versus like at the edge of the table, down in front or behind them. So we actually have eye contact and we're able to talk through and make sure that they're okay. But if all is going well, when we're evaluating, I go right into treatment, which means I might stay there for a little bit. We might spend most of a visit internal. As long as someone's tolerating it and it's clinically necessary, then that happens quite often. Other times, if someone's really painful or they're just not tolerating it emotionally or they don't want to, they're hesitant, then maybe we'll kind of just evaluate a few things and back off, and we kind of slowly work our way back. But when we're doing things like trying to assist that tissue to relax or trigger point release, that's where we can spend more time in there. So we evaluate, we find a trouble spot, and we're able to alleviate it right then and there. So we'll stay there longer.
Mm-hmm. So I do want to share some advice for how I get so many of my patients to buy into seeing a pelvic physical therapist. You showed one of your pelvic models. I'm going to show one of my pelvic models. So I keep this right behind my desk in my consultation room. And I find that once I show people the model and I say, all the dark red that you see, those are all the muscles. And I explain all the different organs that those muscles surround and how it could be a problem with all those individual organs, or the common denominator are the pelvic floor muscles. it's like a light bulb goes off and they're like, oh my God, this is so obvious that it's a pelvic floor dysfunction issue. So I think having a demo in the office is very helpful. And even if it's not like a pelvic model, it could just be an anatomy diagram. I think that would be equally as useful. The other thing that I say is that when they see the pelvic physical therapist, like you mentioned, if they don't feel comfortable with any part of the exam, it doesn't have to be done. There are still so many other ways that they can evaluate and treat the person. And then I also say, hey, with our rectal exam today, during the internal exam, if you feel comfortable with it, then the PT is typically in that area for a little bit longer. And I find it helpful. I do find it helpful to prompt someone that they are going to get undressed. And oftentimes an internal exam is part of it. There is some preparation involved in that, whether it's, showering right before or whatever it is. But actually, that's a good question for you. Is there a way for patients to prep before a PT visit?
Physically? Not really.
Like in terms of making sure they're not constipated before they see you, so you can actually do a good internal rectal exam. Like how might you handle someone if their rectum is full of stool during the visit?
Luckily, that hasn't been an issue because what I explained to them really, because that's their first concern is maybe not the constipation, but like, am I going to poop on the table?
Yeah.
I tell them, if you're sitting here and you say to me, I have to go to the bathroom right now, but I'm not going to do it. Let's go do our exam. I'll probably encounter some things. But other than that, the stool's going to be stored up higher. I'm not even going to notice it's there. We're going to stay definitely more shallow and be right around those muscles that we need to get at. Usually that puts their mind at ease. So generally, it's not really a problem. A couple times we have had people come in if they're struggling with like fecal incontinence. We might choose to defer internal treatment for that day to make them more comfortable, to not cause a problem for them to then get home. But generally speaking, it's really not a problem or something that people have to do much preparation for.
Now, you talked about, the use of just manual therapy, so using our hands, right? Are there other tools that you use in the office, whether it's ultrasound or like anything like that helps you understand, is this person doing this exercise correctly, or can you just feel if they're doing it correctly?
So my best tool is definitely my hand, but we do have a biofeedback machine here. I initially had purchased one because I was seeing pediatrics as well. And of course, we're not doing internal, but the biofeedback machine works really well for people who are not comfortable doing an internal, or maybe someone who is post-surgical and they can't have internal done yet. So your men coming in after prostatectomy, I love seeing them a week out. Now, I'm not going internal at that point in time, but we can use these surface electrodes right over the perineum, and that gives them a visual feedback so that they can really start to see, okay, when I engage those muscles, I see it going up on the screen. So it's great for people like that or people who just don't want to have an internal exam done. Other than that, some other tools that we frequently use to collect data is I use a bladder and bowel diary. So I will have people track over the course of 3 days all their ins and all their outs. So we can start to see patterns that might be like bladder irritants or, hey, you've gone 6 hours without peeing. No wonder when you try to go sit on the toilet and get your muscles to relax, they're not used to being able to relax. Or we can catch the people who are the just-in-case peers using those kinds of tools. Physical tools, we use silicone cups. We do some dynamic cupping over their bodies. And people generally really like that because it's not the cups that leave the marks or cause any pain, generally feels really good. We use kinesio taping a lot. I even use taping to work on scar tissue. So I did that even today. And then our movement stuff, all our equipment that we might use for movement-based exercises as well.
And then we've had some patients where we've discussed maybe the therapeutic benefit of a TENS unit. Are you routinely using TENS units in patients?
So I don't use them all the time. I do have a TENS unit here that patients can try out to see if it would be helpful. I do express to them the benefit of it and how it can be very helpful. TENS unit as well as vibration. So whether we're talking about externally around the pelvis or even internally with something like a pelvic wand. And if they don't have a pelvic wand, sometimes I'll just ask them if they have a vibrator. And just using vibration as a way to decrease muscle tone and help kind of relax everything and ease pain. That's another tool that I'll commonly use.
So that's a great segue to my next question, which is, what are the common products that you would recommend your patients, both vagina and penis owners, get for use at home?
Definitely a squatty potty, because for a lot of the urinary symptoms, constipation is a driver or a contributing factor to it.
Tori,
So
I just got my squatty potty.
Did you?
And it's a game changer.
It is. Everybody should be using one. Not just if you have pelvic floor problems.
But I got the
Everybody
one
should
that
be
you could
using one.
easily collapse. So you can.
Yeah. That's what I always tell people, because their biggest concern is, I don't want that big white plastic thing in my bathroom. It comes in bamboo. It comes in a foldable one. I even have them for my kids in their bathroom. They make little kid ones. So that, hands down, everybody should have on hand. You know, we do recommend a lot dilators and pelvic wands to help with some of the internal tension. We do that both for men and women, vaginal and rectal. Some people do benefit from having a TENS unit at home, but I try to be pretty minimal with how many things people need to go out and get. Even with our exercises, if we're using bands or yoga blocks or things like that, I try to find ways where they can mimic it with things around the house. Squatty potty for sure, though, and a water bottle, because people are not drinking enough water.
And then, do you ever have people sit on a tennis ball?
So that's one of my favorite things, actually, to do for the pelvic floor. Getting to the back of the pelvic floor here, those deep muscles, we can do some myofascial release with either a tennis ball or a Franklin ball, which is filled with air. We basically have them sit on it and do different movements with the pelvis or different movements with their hip to really work in getting those muscles to relax, as well as an actual foam roller. That is definitely, if I ask people to get anything, it's usually the foam roller, because what I find is their adductors are typically very, very tight. And as soon as we release their adductors, the urinary leakage improves, the bladder emptying improves, like so many things get better. And you can make that change without even having to go inside of the pelvis.
When I think about a foam roller, I think like it hurts so good. It's just like, it's so good. I don't know.
Yep. The adductors are great, as well as the obliques. So when you're having people, especially back to my male example with the testicular pain, we can work on someone's psoas, but their obliques get to be really tight, especially your chronic clenchers. So people who walk around with their stomach sucked in all day long, everything gets really, really tight, and we can work the fascia over the obliques, which really helps drive everything downward to relax again.
What about for patients who are frequently traveling? I mean, you and I both see a lot of patients who travel internationally all the time. And is there a recommendation for like a seat cushion they should bring with them on a plane?
There are definitely a lot of seat cushions that I love. The one I really, really love the most is the Twin Cheeks cushion, which basically has two pads that go underneath each side. And so the whole middle section from your tailbone right up through the perineum is elevated. That is pretty pricey, and it doesn't always fit on an airplane seat. So I'll encourage people to roll up 2 towel rolls, let's say, if they're in their car, and mimic it. If they're on an airplane, I tell them to take the horseshoe style neck pillow, turn it backwards so the opening is at the back, and sit on it. And it helps like float the tailbone a little bit and take compression off of it. And then for squatty potty, when people are in hotel rooms, I tell them take the garbage can in the bathroom, turn it on its side, and put your feet up on it. And that's your squatty potty.
These are amazing tips, Tori. So really, when you think about the most common products that you recommend to patients, if they were to get a goodie bag, of those common products, it would probably cost less than $100 for all of them.
I would say so.
Yeah.
Yep.
Okay. That's very helpful to know.
My other favorite one to recommend, since you mentioned travel, is Amazon has these disposable toilet seat covers that are individually wrapped, super small. They can fit in your pocket or in your purse because, again, so many people don't sit on the toilet. They hover. They think they're going to contract something on the toilet seat. And I always tell people, keep this in your bag because you need to be able to sit. You just take one out when you're traveling, put it on the seat. I mean, I send links to that multiple times a week to my patients.
I love that. Last question here for you. Is there anyone you can't help?
No. So the short answer is no. And that's because certain things certainly are going to need medical management, maybe even surgery. But I have yet to meet a patient that we could not help in some aspect of supporting their pelvic health, getting their musculoskeletal system to function better, which then alleviates some of their symptoms, whether it's bladder, bowel, sexual function. There is always a mechanical component that might not be where it originated from, where the symptoms originated from, but it becomes a contributing factor to their ongoing symptoms. So I would say there's no one I can definitely not help. Sometimes PT is not the sole answer, and that's where collaboration comes into play.
Tori, that response is so powerful. It is so powerful. So we should never feel bad about making the referral. And really, for any patient who sees us, they're coming in with a pelvic condition or symptom, and pelvic physical therapy should always be on our list of options. I mean, I can't think of a single patient. I agree with you. I can't think of a single patient who even comes to see me with something as simple as erectile dysfunction who wouldn't benefit from seeing someone like you, because they also probably have some low back pain or some knee issues. So I think that's really good for us to keep in mind as urologists. Dr. Mallow, where can people find you?
So our website is restorepelvicrehab.com. Our office is located in East Delray Beach, Florida. And we also have an Instagram account, restorepelvicrehab_Boca, or you can give our office a call. Our number is 561-571-5582.
Dr. Mallow, it's always such a pleasure to speak with you. Thank you so much for joining us today on the BackTable Urology podcast. And folks, stay tuned for the next session.
Thanks for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
And Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.